So yes, I am a general OBGYN, but in the past 2 years, I've really started to take an interest in different diseases or conditions of the vulva specifically. Since this is a pelvic pain conference, there are pain conditions that are specific to the vulva or the pelvic floor. Specifically, I'm going to talk about two tonight, Vulvodynia and Vaginismus. These conditions are actually not even something we learn a whole lot about in residency in our training. And so it's something that a lot of just general gynecologists aren't very familiar with. By the time I see patients who come to me, they've often had pain for a long time, years, they've been misdiagnosed, and are very relieved when they come and find that not only are they not alone in the pain that they're having, but it actually does have a name. So to start off, I just kind of wanted to review the anatomy of the vulva, just so we're all on the same page here. So this is pretty basic here. This is kind of the labia majora out here, or the larger lips. You have your labia minora in here that meet up top at the clitoris. Beneath that, we have the urethra where the urine comes out, and below that, the vagina. Specifically to my talk, I would like to talk about an area of the vagina called the vestibule, or the opening of the vagina. And this area, it's outlined the outer edge with this white dotted line, and it's kind of all of that area right at the opening of the vagina. And we'll get to why that's important. So starting off just talking about what vulvodynia, what is it? Very general, it's just pain or discomfort of the vulva without any sort of identifiable cause. Specifically, most women that I see have pain specifically at the vestibule, or that area that I just pointed out. Specifically, that's called vestibulodynia. The terms are really used interchangeably. I've seen vulvodynia, vestibulodynia, vulvitis. It's really changed the name over the years, but in general, we'll just call it vulvodynia. But the majority is pain at that vestibular area. The symptoms can really vary among patients. So some patients may just have pain on initial penetration, whether that's during sex or with tampon insertion. And some patients will have pain with sex or to touch, but also will just kind of have this chronic pain all the time of the vulva. Often it's described as kind of a burning or an aching. I hear some people just say they feel irritated all the time. More rarely, it's an itching. And it can be worse when sitting for a long time, wearing tight clothes, biking, anything like that can sometimes make it worse. And so what are the causes? Well, we don't totally know exactly what causes vulvodynia. We do think that it's probably a multitude of factors that are contributing to this. We think that mostly it's probably related to nerves in the vestibule. So at some point there's some kind of inflammatory response that your body has that causes these nerves to start acting up essentially. So rather than interpreting touch or pressure, they start feeling pain instead. And we think that inflammatory response can be caused by different things, one being infection. Can start with a yeast infection, for example. One very common presentation, I see patients come to me and they come to see me for what they think is chronic yeast that they can't get rid of. And they say, well, a year ago I had a really bad yeast infection and I got medication for it and I just can't get it to go away. And then on further investigation, there really is no yeast. They actually did clear the yeast, but they've just been dealing with these symptoms and keep getting misdiagnosed as still having a yeast infection. I see vulvodynia occur in hormonal changes, so in periods of women's life when their hormones are going through changes. So postmenopausal women, when their estrogen levels are decreasing. I see it often in postpartum women when hormone levels are again kind of off. And there's even some studies show that there's even some birth control that we think may contribute to vulvodynia. And some of it may just be genetic. So while I do see some women who come to me at different periods through their life saying that this is, it starts at different periods, I also see some women who come to me who say, younger women from the very first time they've ever tried to use a tampon as a teenager, or the very first time they ever tried to have sex, they've had this pain. So how do you make the diagnosis? Well, of course, talk to the patient, get a full medical history. What other medical problems do you have? What medications are you on? We need to do a full physical exam, and part of the pelvic exam is going to include looking at the skin, making sure there's no other skin conditions that could be causing this pain, and testing for vaginal infections, doing swabs. And then pertinent to this exam specifically is I use a Q-tip or a cotton swab to kind of start mapping out where patients have their pain. Specifically to this, as I mentioned, there's the vestibule. If you think of it like a clock, so 12 o'clock, 2, 4, 8, 10. With the Q-tip, I kind of touch women in those 4 areas specifically, and I ask, is this a poke or pain? In women who don't have vulvodynia, they'll say it's a poke. Sometimes I'll, get, that's a little bit uncomfortable, but of course no one getting poked in that area is not going to be fun for anyone. But women with vulvodynia, if you touch that area, will have an exquisite reaction to the pain. It's often, it's interesting when I have students or residents come and see me because it's really noticeable in women who have it. And then after that, we mapping out the pain there, we assessing the pelvic floor muscles for tenderness as well. Because of course, if you're having pain in that area, whether it's just with penetration or you just have pain there all the time, your pelvic floor muscles are going to have a reaction to that too, becoming tight, leading to more pain, and it just exacerbates the problem. So what is the treatment? Well, it's going to kind of depend on what we think is causing your vulvodynia, and it may involve multiple factors. One thing is pelvic floor physical therapy, as I just mentioned, for the reason that your pelvic floor muscles often play an integral role in this pain and feedback and making the pain even worse. I'm not going to go too into that because Sarah's going to, again, talk about that. If I do believe it's hormonally related, sometimes we'll try topical hormones like a cream on the vestibule. There are medications that we use. They're usually specifically kind of nerve pain related. You may have heard of gabapentin, pregabalin, amitriptyline is another one that Dr. Orwela mentioned in his presentation as well. So some of it is just trying to find the right combination of things. There is a surgery called vestibulectomy where essentially we remove kind of the skin right at the entrance of the vagina in that area that I showed. We usually kind of say that as a last, as our last approach. We try the conservative therapy first. Of course, if we can avoid surgery, that's always more ideal. This is changing direction just a little bit. I just want to talk a little bit about vaginismus. I mean, these conditions do somewhat go together. As I mentioned, the pelvic floor is very much related, to the vestibule and the vulva. But vaginismus is going to be any kind of involuntary contraction or tightening of the pelvic floor muscles with vaginal penetration. And so some women, just the anticipation of pain, there's complete inability often to have any kind of penetration, whether that's during intercourse, again with tampons. If penetration is able to be achieved, it's very, very painful. And this condition does often go along, like I said, with kind of this severe anxiety or fear of penetration that leads to this feedback loop where obviously if you're anticipating pain, you're just going to tighten up even more. And it is often involuntary. I will try to go examine patients and they're like, I'm sorry, I'm not trying to do this. It's just what their body naturally does. I just put this up here just so you can kind of see, if you think of it, so this is that was wrong. This is your pelvic floor. If you think of yourself, I were to cut myself in half and then look straight down. So this is your pubic bone or the front. This is the back. This would be my back going. This is your urethra. The vagina here is in red, and then the rectum. And so you can see how all of these pelvic floor muscles are intricately related to the vagina, and that any kind of spasm of those muscles is going to cause pain or even inhibit penetration altogether. So diagnosis, like I said, often it's diagnosed, women come to me and I'm not even able to really do any kind of exam or any kind of digital exam or look in the vagina with a speculum. If I am able to do kind of a digital exam with feeling the pelvic floor, the muscles are going to feel very short, tight, and they're going to be very tender. And then of course, ruling out anything else that may be going on. The causes can be somewhat similar to vulvodynia, infections. It can be other things like a history of sexual trauma, or even I see it tends to have patients who kind of grew up in like a culture or even a household where sex was very taboo. I see more of this. Again, we treat this mostly with pelvic floor physical therapy, which I won't get into too much, but dilator therapy. Dilators we use, they're gradually increase in size. Patients can do them on their own and in conjunction with our physical therapists. Sometimes we're able to give medications that help aid in relaxation of the pelvic floor, like vaginal Valium suppositories. Some people are even doing Botox injections in the pelvic floor. And these are really kind of temporizing measures, but they're really just to help get through the pelvic floor physical therapy part to work on the relaxation. And then again, I usually encourage mental health support, and this really goes for the vulvodynia as well, but it really does, have there's a psychological component to it. I mean, of course it makes sense if you have pain, you're not gonna wanna have sex, low sex drive, all of that kind of thing. And so there really is this kind of mental part that sometimes you have to overcome in conjunction with working on the physical therapy.